Okay, high expectations. Perfect. Thank you, Rick, for having me here. I've always been at Stanford. I joined in 2005 as a postdoc and never left. So I've been on the farm in a 3-mile radius practically since then. Never had a real job. I still don't have a real job. So what we're going to try and do today in the first 40 minutes is I'll give you a flavor for how things are shaping up with a few examples. Most important, how should we think about these technologies and their role in healthcare? And I'll start with sharing where I'm coming from. So on the left, in the red, is my job as a professor in medicine, where I do research on how do we develop the methods that bring AI into routine use safely, ethically, and cost-effectively. And I'll underline cost-effectively because last I checked, we're trying to reduce the cost of healthcare. I teach data science in more graduate programs than I should, in 3 graduate programs and in 2 online entities. And then I'm quite active in speaking about how we should think about the data science ecosystem on our campus. And that's sort of a cultural thing here, as Rick was saying. We want to be at the cutting edge. The joking way of saying it is that Stanford hates to be second. The fear of being second is what drives us the most. And then on the right is my job in the health system, Stanford Health Care, with Mike Pfeffer, our CIO, who's right here. The goal is to lead a team that can actually bring these algorithms into the healthcare environment. Because writing a paper is easy, like I have 300 of them, so it's great. And then building the delivery science, that how can we execute on what the algorithms tell us. That's not easy, actually. In fact, that's like 80% of the work. And then cross-functional leadership. We have multiple clinics, multiple service lines, clinical departments, 2 hospitals on the adult side, 1 children's hospital. How do we all stay together? And then represent Stanford, and this is not made up, they all believe I'm the world leader. I will let that illusion persist. But in proper genealogy, I would say I'm sort of the grandchild of healthcare AI. It started on our campus in 1974, the graduate program for that, started by Ted Shortliff. And Ted is sort of my academic grandfather. I trained with his direct student. And so, yes, right now it's hot and everybody talks about it, but for those in the field, it's a community of about 3,000 faculty across the whole country that have been thinking about this for several years. I happen to be one of them. All right, so that's where I'm coming from. I'm sharing all of this detail because I think the thing about AI is to understand the perspective of why whoever is talking to you about it is talking to you about it. There's been lots of people who will talk to you about AI just because they want to sell you something. That is not what we do in healthcare. Okay, so this is perhaps the most important slide in our conversation, which is that AI comes from data. And when people think of data in other industries, you think of files or documents or pictures or sound. In healthcare, we have to think of a timeline. Because anything in healthcare happens over time. So here we have a fictionalized timeline going from left to right. And this particular individual got admitted to the hospital 4 times. And in one stay, they ended up in the ICU twice. This is all sort of administrative things. And then we collect a whole bunch of data. In this case, ECGs, cardiac output, vital signs, medication orders. We write some documents. We monitor fluids and so on. This thing, let's give it a name. Let's call it the patient timeline object. In the data warehouses we maintain, these data are split across about 1,200 IT systems. 1,200. All of that needs to be assembled into a cohesive construct. And then even if you can conceptually assemble it, 2 things remain true about this, is that there is no entity not Tri-Valley, not our 500p or 300p setups, not our insurer, not even the patient themselves, where if you pick a data modality like ECG, nobody has a 5-year continuous record of any given modality. And if we pick a point in time, there is nobody who has all the possible modalities that are measured at the same time. Because, like nobody wakes up saying, I'm going to measure 100 things on me today. We measure something when it's necessary. And so these two things are really important because the people who come up with algorithms for data mining, AI, and whatnot assume complete data. Whereas we're dealing with this thing that is incomplete in two ways. We don't have it continuously measured over time, and we haven't measured everything at a given point in time. And there's probably 100 things to measure. Every hole in the body, we can put a camera up and take a little video or a picture. We can put sensors on multiple parts of the body, record electrical signals that we then convert into something. I mean, it's endless what we can measure. So good AI begins with data, and that is the foundation. Stanford started this journey laying the foundation for a good data infrastructure in 2005, right when I arrived on campus. So that 20-year investment, 19-year investment, is what enables us to be at the forefront. All right, so we take these data and then we build models. I'm not going to show you formulas about the math that underlies it. From a conceptual standpoint, it's actually not that important. You feed in these data items, some math happens, and out comes a number. Logistic regression is sufficient to sort of conceptualize what's going to happen here. So these things, these models, in healthcare do two things and two things only. They help us make decisions of whether to treat somebody or how to treat somebody. I would argue that at any given point in time, those are the two decisions that need to be made. In a clinical situation, there might be 50 of these, or 25 of these, or 100 of these simultaneously. That, you have to decide whether to treat your diabetes, have to decide how to treat it, have to decide whether to treat your heart failure, have to decide how to treat it. And often when 5, 10, 20 things collide, like they don't always agree with each other. That's why it takes a while to train and become a doctor, and you have to keep up your skills and so on. But at the fundamental level, at the conceptual level, it's two decisions. Should I do something, and what should I do? So the should I do something, the whether to treat, from a computer standpoint, further is two different decisions. Decision one is figuring out what the person has, otherwise known as diagnosis or classification from a computer standpoint. You might, in general speaking, hear statements such as, we examined this image with deep neural nets and we predict there's pneumonia in there. That's like saying, I analyze this image and I predict there's a dog in there. Well, the thing's a dog before you took the picture. So there's no prediction going on there. It's classification. It's figuring out what already is. Prediction is I tell you tomorrow's temperature or NVIDIA stock price tomorrow, and then you check whether we got it right. So that's forecasting. That's prognosis. So about 80-90% of things in medicine that masquerade as predictions are really classifications. They're just figuring out what is. And that's important, because once you figure out what is, you can engage the human mind and do something about it, as opposed to force the human mind to be spent on figuring out what is. This is really important. The how to treat is computationally quite difficult because it requires something called causal inference, and you have to reason about the state of the world that didn't happen. And so a lot of math goes in here. Often people say we're going to look at similar patients. Like, I still don't know what a similar patient is. It depends on the situation. And so figuring that out is like statistics is involved, data science is involved, not quite AI as commonly understood. And then I'll add one more thing here, given generative AI, and that we're going to talk about it, is that we can basically summarize, as the example Rick was giving about a computer listening and summarizing a conversation. You can do summaries of text You can do summaries of pictures. In fact, you can do a summary of the entire timeline across multiple modalities and produce a paragraph. It's possible with today's technology. All right, so that's what the tech does. That's the rows here. But the columns are what are we doing it for, the why. And that really matters. We can do it to advance the science of medicine, the practice of medicine, or the delivery of medicine known as healthcare. And I'll walk you through an example, and we'll walk through this first row just for simplicity. So I know there's at least one cardiologist here. Are there any other cardiologists here? All right. I love making fun of this disease. There's a disease called heart failure with preserved ejection fraction. And my department chair was a cardiologist, and we had a lot of fun about this. So you ask a physician, what is heart failure? They say, well, your heart's not pumping enough. Well, then you say, what does preserved ejection fraction mean? Well, it is pumping enough. Like, well, wait a second. So you just said there's this disease where your heart is not pumping enough, but it is pumping enough? But that is a thing. That is a diagnosis. That is a sign. People do have this phenomena where you have all the symptoms of what looks like heart failure, but your heart's pumping fine. It does happen. So like, it is a thing. So a bunch of researchers analyzed this condition, looking at echocardiograms, EKGs, gene expression, lab test results, and so on, and did some classification and figured out, you know what, this thing is actually 3 conditions. And if you're subtype 1, you're dead in 2 years, and if you're subtype 3, you're fine for a decade. So that's nice. That's a fundamental advance in the science of medicine, that now we know that this particular item that we thought is one disease is in fact 3. And that happens in medicine quite often. We used to think diabetes is one disease, and now we have type 1 and type 2. That happened, several decades ago. This is more recent. Scientific advance. Pinnacle of achievement, you publish in Nature Science Cell. Or you get a Nobel Prize, right? And we have like 7 living Nobel laureates just on our med school campus. On the practice side, we need 2 more things. I need a test. Patient walks in, I can order this thing. It could be a blood test, it could be an imaging test, it could be an EHR-based algorithm, AI, don't care. I need a test that sorts people into 1, 2, 3. Remember Harry Potter's hat, sort you into the house? And then, so I need my test, and then I need my treatment, because I need to be able to do something different for those that are at higher risk. And I need to be able to not do something for those that are at lower risk. So guidelines need to evolve, treatments have to be available. And so if not, we're just increasing the cost and complexity of healthcare by just doing more testing. So that advances the practice of medicine. Pinnacle of achievement, you publish in JAMA, New England Journal, or Lancet, you do a clinical trial, and so on. Delivery changes. If we've figured this out, we know there's 3 subtypes. We have the test and treat regime. We do it for 5 years for 1,000 people. They live longer or cost less or both. That's when Rick and David Entwistle take notice, and that's where the CFO sees the effect of this. Both CFO of the health system and the provider network, and government officials and people who fund Medicare, because now you're doing something that is saving lives and hopefully money at the same time. So AI can be used for all 3. On our main campus, we do all 3. Here in the Tri-Valley, hopefully in the discussion, we'll talk about how we're doing some innovative things that will be done first on the Tri-Valley site as opposed to our main campus site. All right, so I'll share a couple of examples of this. So let's look at one here. This one is in the harder row, the recommend, and in clinical practice. So medical evidence advances by doing these studies, often called observational studies, because we can't do an RCT, randomized controlled trial, for most things. And typically what happens is that someone has a question, you describe the patients, the intervention, the cohort, the outcome, and then you go get your data, you talk to your statistician friends, you do your study, you write a little paper. It takes about 9 months. We did this project, which was called the Green Button Project, and there's a fun story why we called it that. We thought it would actually be a button you press, but turns out that doesn't work. Doctors hate tools. They like referring to their friends, so you have to set it up as a service. So it's a service that we ran for about 2 years at the bedside, where we would receive a referral about we have this clinical situation, or we have this child with a mononeuritis multiplex, and we're going to do a spinal tap and all of these other testing. How have other kids like this been treated? And within a day, we'll produce a 2-page report and an interpretation signed by a physician who understands data science. And so in this scenario, that's a 137-fold increase, 9 months to a day. Lots of AI, lots of data science, lots of that, but from a patient standpoint, now you can get a report of what happened to similar patients. I've used this in my own care as well to make decisions. And why does this matter? Because this is the state of affairs. In about a week, this group of physicians, I'm not involved with them, and I don't know how their week is 7.5 days. Like, I wish my week was 7.5 days. But in about a week, they tracked the decisions they made and then went back and found that about 80% of the decisions had no basis in any prior published data. Less than 3% had a study specific to the question at hand. This is reality. This is why human doctors are not going out of business. You need a human to take the best guess as to, given the evidence, given what they know, what is right for this person in front of me. And so we were able to plug this evidence gap by analyzing the prior decisions that our own physicians had made, and we dutifully recorded them in our 1,200 or so different IT systems, and we just surfaced them back again. So when we finished this project, our Dean Lloyd Minor and David Entwistle, our CEO of the 500P hospital, said, so how are we going to scale this, right? We want to help the whole world. We want to impact healthcare one patient at a time, but we want to scale outside. So I said, me and my 2 students, we're not going to do it for the whole country. No, hard pass, not interested. And so we spun out a company called Atropos Health in 2021, in the midst of the pandemic, which still retains this moniker Green Button. And essentially, in a day, you can get a report of what happened to similar patients. And of course, given ChatGPT, now they even have a bot that you can talk to. The bot's just interviewing you, asking, what is the exposure, what is the outcome? The statistics is actually done by open source, battle-tested software packages. Okay, let's look at one more example. Here we're in the predict row, where we're making predictions of something that sounds kind of bad. We're making predictions about who's likely to pass away in the next 3 to 12 months. And there's a reason to do that. We're not making those predictions to decide what care to give. We're making those predictions to decide who should be seen and have a goals of care conversation and advanced care planning right away. If it's less than a year out, it's too early to have the conversation. If it's less than 3 months, we're sort of falling into this trap of over-treatment. 80-90% of people, when asked, say they want to die in their homes, but 80-90% of the people still die in the hospital. So something is wrong with this picture. So we built a model. The model took us about a few months to develop. And then the model identifies someone who's at risk of dying. Now, what do we do about it? At that time, the thing to be done, this advanced care planning, it would have taken 3 human beings, 48 hours and 21 steps and 7 handoffs in order to successfully complete advanced care planning. And they could do 3 to 5 a day. So we partnered up with our physicians, Dr. Vinnie Tutberg, to simplify the process by which the intervention can be executed. Long story short, now we're at a stage where the number of patients that are getting these conversations is rising. The number of conversations that a physician has to do is flat or declining. And that's really important because we can't just keep putting the burden of following up on the doctor all the time. In this case, the serious illness conversation planning is done by, in some cases, by the physical therapist, by residents, fellows, med students, spiritual care workers, and we track who's having those conversations. Are they getting documented? And are we following up on them accordingly? Dr. Michael Gensheimer is doing a prospective evaluation that by having these alerts, what happens? Do we follow up appropriately? Net, after 6-7 years, the rate at which we do appropriate advanced care planning is upwards of 15%. Changing our Vizient rankings, providing better care. For me, I've been tracking this for about 7 years. 6,700 people up till now have gotten this conversation that would otherwise have been missed. Now, the reason why I'm diving into this so much is that the model stratifies by risk. Value comes from that responsive action, and it is up to us to decide what the responsive action is. When we published the model, there were people coming to us and say, hey, if we can predict mortality, can we use it to price insurance? There were people who would want to use that to selectively enroll people in Medicare Advantage plans, and then take reinsurance on them, because if your subscription expires, then you can actually go collect from Lloyd's London. I mean, all sorts of nefarious uses can happen. But it's up to us what we do with it. That's where Raise Health and the ability to think through what is the right action comes in. We have a patient and family advisory council that was involved in figuring out how do these conversations happen and what is the next follow-up step. So that's this one example. There are other things we can do, like fancy things, like look at CT scans and EMR data, and CT scans of the abdomen, and actually Dr. Rodriguez is involved in that study, and figure out somebody's cardiovascular risk. This is magic. But then we have to figure out what we're going to do with it. We can also do mundane things like predict no-shows or length of stay, readmissions, bed demand. But all of that is worth doing if and only if we can do something about it. So this is a long way of getting you to this one sort of Mercedes-Benz logo kind of slide, that there's an interplay amongst models or work capacity and policy, not as in government policy, as in at what threshold are we going to do something, that kind of policy. And then the actual action we're going to take and its harms and benefits. We spend way too much attention on this. That is where the media is focused on. We, on our campus, like to focus here, because that is how we can ensure that the AI that we use is going to be fair, useful, and reliable, and monetarily sustainable, cost-effective. So the key thing that we do different beyond everybody else is that this is sort of an odd-looking plot. The point here is that, let's say we make a bunch of predictions, we can rank order them based on probability, or 1 minus the probability, so that's why it goes from 0 to 100. And then when you take action, if your action works, there's some benefit. Hours saved, money saved, happiness accrued. Doesn't matter what your utility function is, but it's in some units. And as you take action, you start accumulating utility, and then it starts going down because you're kind of wasting effort, diminishing returns after a while. So the key thing is, how far down the list can we get? Because if there's no capacity to follow up, we could run 100 models, no problem, and have alerts and emails and text messages flying around. But if we can't follow up, nothing good comes out of it. So we pay a lot of attention to that side, the workflow side of the house, so to speak, than just building the model. All right, so now AI is in the public consciousness and conversation thanks to ChatGPT as of November 2022. But faculty have been studying this for a while, and then there's a certain way in which we're taught on how to build a model and externally validate it and so on. And what I'm going to show you is sort of how absurd the academic mindset is in today's age. So these are real numbers from Dr. Maya Yidam, who's one of our ED physicians and vice chair for clinical translation in their department. And this is like impeccable science, okay? Like the best bar of quality that you can meet. They built a model that if you walk into the ED, who should get an immediate EKG, multi-lead EKG? Validated at 4 sites, grant funded, and so on. And it took them 10 years and about $28 million. If we keep doing business in this manner, just across Stanford's 89 or so sites of service and the 123 fellowships and residency programs, if one person wants to build a model every year, that's like $138 billion. I can't afford it. And so the way we think about this now is that, what is the readout we're going to hope for? So we'll walk through this standard AI. Right now, we're too costly and too slow. And we're trying to speed that up. We've set up a team that does data science for a living, where we want to get the production cost of these models down and want to get the execution of these workflows streamlined enough that we're not operating at this level. And so let's just call it the discovery phase. We want to see feasibility and user acceptance, and we want to get down from this slow and expensive universe. Then next stage, we want to focus on this achievable benefit. Do we have the work capacity to follow through? And if all of that works, then we have to have this hard conversation about business model change. Because often what happens is that a prediction happens, but the follow-through requires things that somebody has to pay for. And you have to figure out a way to work with insurance on that. And the value is going to accrue to the employer or the insurer or the county or your Medicare or Medicaid program. And so you have to figure out that if the health system does the work, how are we going to sustain it long term? Because you can't keep doing this as research projects over and over again. The good news is that for here, we have a mature worldview. It's not perfect in terms of executing end-to-end very fast, but at least we know what needs to be done. The problem is clarified. And then along comes Gen AI. It's kind of unclear how are we going to navigate it. There are a few things that it's really good at, like summarization. But we really need to focus on verifying the benefits, because the media has kind of gone a bit nuts on this. So what do I mean by that? So we did a little survey of about 520 papers that reported something about using LLMs, large language models, in medicine. And we asked 5 questions. Question 1, what's the data you're evaluating on? Question 2, what's the medical task you're doing or healthcare task you're doing? Question 3 is what's the language task you're doing? Question 4 is what are you evaluating? Question 5 is what specialty? So the first one, it's not on the slide. 85 or 90% of studies were doing their work not using patient data. I was like, why should I even trust your results? Then the healthcare task, we love answering questions. 222 papers were essentially doing question answering and examining them by how many USMLE exam questions you got right. So the healthcare task, enhancing or checking knowledge. The language task, question answering. And we're in love with accuracy. Pretty much nobody asked, can you afford to run it? Because if every API call costs you $5, it adds up pretty darn fast. And then specialty-wise, it was mostly dominated by internal medicine and dermatology, surprisingly. So that's the state of affairs. We don't really have a good handle on how to evaluate these things. We're evaluating it for answering USMLE exam questions, but then we want to use them for something completely different. And how can we trust that leap of faith? So we think, and we here, I mean Mike Pfeffer, who's with us here, and David Entwistle, we wrote this article that we really need to figure out a way that how are we going to define and verify benefits? Both. And defining is actually the hard part, and I'll walk you through 3 examples. So I showed you this survey where everybody's taking USMLE exams and then claiming that GPT passed the exam, so it's a great doctor. So it's all right. Let's see how they do at the bedside. So I told you about that project of bedside question answering. So we took some of those questions and sent them to GPT 3.5 and 4 and asked 12 physicians to rate the answers in terms of, do they agree with what we know, do they disagree, or you can't tell. Good news, agreement is up, disagreement is down, can't tell is down. So great progress in technology. But the headline result is about half the time the 12 physicians can't agree what is the case. Like, ouch. That's like having a person at the bedside who speaks very cogently, confidently, and half the time they're wrong and you can't tell. Otherwise known as a second-year med student. So like, okay. So then we said, all right, people want to use these language models to complete medical tasks. So we collaborated with 15 clinicians, 7 specialties, and collected these prompts, these kinds of things. Sometimes they're called prompts, sometimes they're called instructions. Like summarize from the EHR the strokes the patient had and their associated neurological deficits. Like something a doctor might reasonably want done on the record. And then for a few of them, about 300 of them, we also have them write the correct answer. And then we give the prompt and the EHR to the language model, and the language model writes an answer. And we did that for multiple language models. And even in the best case, 35% error rate. So now if I were to ask you that would you use a piece of technology in making decisions about your patient when there's a 35% error rate, most doctors are like, not interested. And then the other hard one is discerning efficiency gains from productivity gains. And this was something that we were part of, UC San Diego is part of. There's no image for that. We used language models to respond to patient messages coming in the in-basket, as it's called. And the hope was it would save time. And if it did save time, that would be a huge productivity gain. Well, it turns out, 0 time savings. Dr. Patty Garcia led the study. Mike is the senior author on there. UC San Diego had an even weirder finding that there's a 22% increase in the time it takes to read the messages now. Because you have to read the message and you have to read the generated response. Now, it's efficient in the sense that physicians love it. Their cognitive load has gone down. Because, this is work you're doing in classically called pajama time at 8 to 10 p.m. The time is still the same, but the agony has gone down. So that is an efficiency gain for your workforce. Like, they should not have had to suffer through this, and now you're providing tooling to mitigate that suffering. No new patients are going to be seen from 8 to 10 p.m. It's not a productivity gain. And so for Gen AI, you have to straddle this balance of, like, what is the rubric under which we're going to evaluate and adopt this technology, and productivity is not going to be the winner here. It's going to be something else. All right, so we have about 6 minutes left. All right, so I'm going to show you a couple more things, and then we'll go into the Q&A. So this is verifying benefits of off-the-shelf LLMs. But what could we do here, like cutting edge, as Rick was saying, pushing the envelope. So the patient timeline, if you think about it, has a language. Now, when people utter the word language, and I put it in quotes because of that, we think English, Spanish, German, sort of natural languages. But for a computer, any sequence of tokens is a language. Amino acids in a protein, language. ATCG in a DNA sequence, language. These ICD, CPT, and those codes in a patient timeline, language. And that language has a grammar. When you see 250.01, code for diabetes, ICD-9 code, I haven't memorized my ICD-10s yet, you expect to see metformin later. You expect to see glucose measurements in the blood and perhaps even the urine. You expect albumin measurements. So that language can be learned by a computer using the exact same technology as is used to learn language models in spoken and natural languages. So now that gives us 2 ways to build language models. The first is the classic language that reads documents, and you get a model that does chat and summarization. And then the second is reading these timelines and then forecasting what's going to happen next. Remember prediction? So what happens if we do that? Well, it turns out that if we take these timeline-trained language models, it's better all around. Like we can increase prediction accuracy, the classifiers decay less as time goes on, they work across subgroups, across sites, yada, yada. But I want to make it very concrete visually. So here is the number of examples you need to train a classifier or train your AI. And here is performance on this side. Pay attention to the blue line. At 64 positive examples, it meets the performance of the red line, which is trained using all the data. I can train classifiers with 64 examples. Now that's awesome. We can build 100 classifiers now. And it's not going to cost me 10 years and $27 million. But the workflow work still remains. Like, what are we going to do about them? So we're pushing the envelope on both. Like, we're figuring out how to do this sustainably at the technology level and figuring out how can we sustain it from a workforce level. So all that sort of comes together in this team, which we call the data science team at SHC. This is a public URL. It will just take you to a static page because most of it is on the internet. And there's a link saying, if you're SHC, click here, and takes you to the intranet site. But we do 4 things. Like, we keep our thought leadership in responsible AI. How are we going to study this interplay to make sure we get it right? We do these assessments to make sure that these models and the workflows associated with them are fair, useful, reliable, and sustainable long-term, fair, useful, reliable models. A ton of work goes into here, a ton of work. Not visible, but we have to create both the infrastructure and the business processes that across the multiple service lines and the IT departments and so on, we can execute. And then we do want to execute 3 to 5 projects that have huge value for the health system, for a patient population, across at least one of these multiple domains, quality, patient experience, workforce wellness, or financial strength, ideally more than just one. And as Rick had mentioned, we do have about 30 plus applications, so that was indeed a correct number. And in the panel, we'll talk about some examples of that. They're administrative, patient engagement, clinical quality, and efficiency. It sort of hinted at the efficiency one in the in-basket example. And I'll close out with a picture of the amazing team. So IT, TDS is about 1,000 people, so definitely not all of them here. But this is the team led by my sort of close colleague, Anurang Revri, architecture, integration, and data science. And then these are sort of the school side students, postdocs, and researchers who are kind of embedded in that team. Some of them are actually in the picture as well. So that's how we make it all happen. And about 1 minute, 50 seconds left, so we'll end early and then go into questions.